One, Camille Cotton from Transplant ID. I think I'm going to start us off. We had a bunch of questions, so we'll start with those. So one of the first questions we got was, how do I prevent myself from getting infectious diseases? Should I wear a mask and attend activities? Is COVID over? So COVID is not entirely over, but we did learn a lot during the pandemic about how to protect ourselves from infection. I do think that influenza rates are really down now. RSV rates are really down. Lots of respiratory illnesses are, really low, much lower risk now. So I think everyone can relax to a certain extent. But, if you are out, if it's a crowded location, if you're doing something you don't want to get sick at that point, by all means, wear a mask. I wear a mask when I board an airplane. I just don't want to get sick. So we learned a lot during the pandemic about hand washing, wearing a mask, and just avoiding crowded locations. But certainly, there's a risk benefit to going to a wedding, going to social events, and so we do encourage a normal return to life. Although thinking about perhaps masking, especially if crowded, or if someone near you appears ill, maybe move yourself away from them. So, another good question. Measles, should I request records from pre-transplant testing 24 years ago or check measles titers now? And so the answer here is luckily we have very limited measles activity here in New England, and we have high rates of vaccination, which is definitely protecting us. Community immunity protects all of us, especially people who have suppressed immune system. We have seen disease outbreaks of measles periodically for decades without major spread. And usually what the experts talk about is dropping that measles case into a well-protected cohort, and the measles sort of self-extinguishes because of everybody being vaccinated. When there's less vaccination, there's a higher risk of spread. But so far, we haven't seen that in New England. I would like to emphasize that anyone who's on active immune suppressive agents should not get the measles vaccine, also called MMR, in that you really want to make sure that you don't expose yourself to the risk of potential significant side effects. If you are waiting for a transplant, you can get the MMR vaccine before transplant. And then if you are in between, say, kidney transplants and on very low dose immunosuppression, you might be able to get the MMR. I'm happy to see you for that, or you can talk to your transplant team about that. And I know that since I've been running the Transplant ID clinic, almost everyone has had pre-transplant measles titers checked. Only about 4% of people are negative, and most of them were offered MMR vaccine. We've done a safety review. And so we have protected you. And even if you were positive 20 years ago, we still consider that to be protective now. So good news about that. I hope that decreases some of the anxiety and potential confusion that's out there. So most transplant patients are protected, and you should not be getting extra doses of vaccine. Here's just how measles has looked this past year, but just to emphasize that last year, as you can see on this map, the darker blue states had measles activity. So there's a lot about measles right now in the news, but actually last year and even the year before, we had measles activity happening. So this isn't entirely something new, but it does seem to be amplified in the press, in part because it's emphasizing certain political issues. We have seen a decrease in vaccination rates of kindergartners in recent times, and you can see that the blue states are well vaccinated. We want at least 95% childhood vaccination in order to provide protective immunity. So as the states turn sort of light orange and deeper orange, those are areas that would be at higher risk for spread due to decreased community immunity. The next question is, what is the recommended protocol for how often a transplant patient should be vaccinated? And so, oh, sorry, there's a typo in the top, but for COVID-19, RSV, and flu, everybody should get a flu shot every fall, best if this is in late October or early November. so that you optimize protection during the flu season. I see a lot of people who get these vaccines in August, and I think that's a little too early. Almost every year, we only see influenza activity pick up in December. So it's okay to get that vaccine every fall. All transplant recipients and people 65 years of age and over should get a COVID vaccine every 6 months to prevent severe disease. And that's pretty straightforward. Even if you've had all your vaccines until now, you still need to keep upping those. It's like I need to change the oil in my car, that kind of thing. It's still there. All transplant patients 60 years and over should get an RSV vaccine once. And that is actually something that may be changing at a national meeting we're having tomorrow, in that it could drop to 50 and over, but we're waiting on that recommendation. But for now, it's 60 and over. Everybody should have an RSV vaccine. And all pre or post-transplant patients all adults should have 2 doses of the Shingrix shingles vaccine, and that's pretty straightforward. I have to say it's amazing. Since 2021, when we started giving everyone the shingles vaccine, I almost never see shingles anymore, which is wonderful. It was one of about 50% of transplant patients got shingles at some point in their lifetime, and we've dropped that to not quite 0%, but very, very low. So great news. Okay, and I think that's the end of my questions, but I'm happy to have questions in the Q&A. And let's see who's taking over the next group of questions.
Well, there's a question in there about COVID. It's very specific. Paxlovid is not appropriate. Do we have access to other
Hmm.
drugs? Thoughts on that?
Yeah, it's a great question. So actually, it says in molnupiravir is of limited effectiveness. Actually, we've had pretty good clinical success with molnupiravir with people who are quite well vaccinated. So I wouldn't say that we have little to worry about concerning COVID-19. I still don't think people should get it. I do think they should get vaccinated every 6 months. But with molnupiravir, that's a pretty good level of treatment effectiveness. That's what I would say about that. Oh, and if you had COVID, do I also need to get a vaccine? Yes, we'd recommend that you get the vaccine 2 to 3 months after having had COVID because you could get it again.
Dr. Cotton, are we still testing for COVID when you come in for a transplant?
I believe we are.
And if
I
you're
believe.
positive, are we canceling the transplant?
Well, let's see. Why don't I ask my colleagues about that? I think it depends on the overall situation and if it's an emergency. So if it's somebody who's inpatient, an emergency liver transplant, and somebody who might have had symptoms for a while might be a different situation. Um, I'm going to call on Brian Keller, who runs the lung transplant program. Brian, what are your thoughts about that?
Yeah, so in lung transplant, we are testing recipients who are brought in for transplant, and if you do test positive, the transplant is canceled until we have either evidence of clearing of the infection or at least an understanding of where we're at in the infection. Because obviously COVID is going to directly affect the transplanted lung, whereas it may not affect, a kidney or a liver. So we do have to be very careful because these viral infections in lung can trigger rejection and increase the rate of chronic rejection in our patients.
And so I think for liver, it would be lower risk. Heart and kidney, it would be lower risk. And we are taking donors who are positive, but sometimes it depends on the individual. We tailor that situation to the individual situation.
Yeah, we have sent canceled one transplant due to positive COVID on someone that came in from home and used the liver in someone else just because we didn't want to take the risk related to some of the things that you're talking about. But you're right, it's an open thing to kind of monitor. But I think if you're feeling sick, then you have to let us know as soon as possible and maybe not come in for the transplant unless it's life-threatening and we can do the workup and go from there. There's some long questions here.
Oh, and then there's a question about the pneumonia vaccines. It's a super complex situation in that we've had a bunch of new pneumonia vaccines in recent years. And so it sort of depends on the situation. But if you haven't had the Prevnar 20, you should probably go out and get the Prevnar 21. If you've had the Prevnar 20, that's probably good enough. That makes it pretty simple.
And those are the pneumonia vaccines, correct, Camille?
Yes, the pneumonia vaccines, yes. And everybody should have that optimally before transplant, but if needed after transplant as well.
Thank you. I think there's also a question, Camille, about people getting vaccinated and then tracking the antibody levels, for example, for hepatitis B, and seeing that the titers are not going up, so these antibodies are not going up. So what do people should do? Should they get additional vaccines, and what's the general recommendation?
Yeah. Okay. I can't quite see that question, but so it's hard. Vaccines work less well after transplant, and so we do recommend people get the hepatitis B vaccines and other vaccines before transplant whenever possible. If they are after transplant, we do recommend getting 2 doses of Heplisav given a month apart. And yes, Leo, actually, Emily, Dr. Bethea and I were talking about that earlier today. And many people don't convert their antibodies. So then we try multiple doses of high dose hepatitis B vaccine, but even then, sometimes they don't, often they don't convert. And so, we give it a try, but after that, we sort of stop. But we do the best. We do the best we can. Mm.
There's one
Happy to
question.
answer the,
Go
oh,
ahead.
Leo, please. No, no, I was going to
No.
say there's a question here about which vaccine should I be taking or not if I'm immunosuppressed. And I think there's probably 2 points to clarify here. If it's immunosuppressed and post-transplant, the level of immunosuppression is probably going to limit to not getting the live vaccines. And I can let Camille weigh in on other factors. If it's immunosuppression, the type of immunosuppression matters if, for example, you're on the wait list and you're pre-transplant. If you're a liver patient and maybe you're on something like CellCept, which has been discussed here, mycophenolate mofetil for autoimmune hepatitis, there are some things you can still get, and we don't need to avoid certain, for example, live vaccines. It depends a little bit more on the type of immunosuppression you're on. So you can definitely talk to your team directly. And Camille, I'm happy for you to weigh in on anything else, or anyone here on the live and other factors.
Yeah, we don't recommend the live vaccines after transplant without very careful discussion, which is why we can't give the measles vaccine or things like yellow fever vaccine for travel. Or chickenpox vaccine, but in general, most of the other vaccines are fine.
How long
And
do we
for
wait
it,
wait for the live vaccine after a transplant?
yeah.
Does it vary?
So usually we should wait a month. We've actually spent a long time reviewing that. We're writing guidelines for the American Society of Transplantation, and people can have vaccine in their bloodstream for up to 2 weeks, it looks like something like that, after getting the measles vaccine. So to be safe, we double that. So we say 4 weeks. But if there's an urgent transplant situation, we would, as we always do, come together as a group, discuss and weigh risks and benefits. And sometimes we might proceed to transplant a little on the earlier side, depending on the individual situation. So it's not like so many of the things we do, it's not necessarily a hard stop, but a group decision, weighing risk and benefit.
Just to clarify, you're speaking about the pre-transplant vaccination in terms of the things like MMR as opposed to
Yes.
post-transplant. Yeah, it does come
Yes.
up in the heart world where we're very eager to get a patient transplanted. And, if somebody is in need of very expedited transplant, we steer clear of the live vaccines because we don't want to find ourselves in a situation where we've just given a vaccine and then we have a waiting period in which we wouldn't want to accept offers.
Right. So we often avoid giving vaccines to inpatient people who are sick enough to be inpatients. We often avoid giving them the vaccine. But we do the best we can. Sometimes we don't have enough time to give people the vaccines they need before undergoing transplant.
There's a question regarding kind of the balance with our immunosuppression and in situations where patients are getting infections such as different viruses, and how do we approach our thinking about that. And I'll just say that I think depending on which organ you receive as a transplant, there's different levels of immune suppression that we use. Some organs don't require as much versus others. And we're trying to find this magical sweet spot where the immune suppression is sufficient to prevent rejection, but not too much to where you're getting repeated infections. And so we kind of balance our dosing adjustments depending on what we're seeing in terms of rejection versus infection. Some of these infections though are seasonal, and so they're just higher risks for certain infections like influenza, RSV, certain times of the year. And so while yes, adjusting the immune suppression can increase or decrease your risk for certain infections, sometimes we need to do other things. And then in the question, they mentioned intravenous immunoglobulin, and that can be a way to boost protection against infection while also not ramping up the immune system to increase the risk of rejection.
And building on what Dr. Keller was saying, so there are some specific infections that, for example, may affect preferentially the kidney. And I think there was a question about BK, which is a virus that infects only the kidney cells. And in that case, unfortunately, there's no antiviral to treat that virus. And we use the reduction of immune suppression in order for the immune system of the patient to actually fight the infection. There are few studies, clinical research studies ongoing to study some new treatments for BK. And so what we do is we encourage our patients to talk to their providers to see if they qualify for these studies. And hopefully in the near future, we may have more specific treatments. But for some of these conditions, sometimes reducing the immune suppression is one of the key essential pieces in order to get rid of the infection. There's one other question about dental infection post-transplant, or maybe we'll start with dental procedures. We tend to avoid dental procedures on the first 6 months. Of course, if they're emergent, that is okay. But remember that early after transplant, our patients get more anti-rejection medications, and so they are more prone for infections. And as time passes, that risk will diminish somewhat. Of course, we're always going to be cautious on it. And we tend, in general, not to recommend antibiotics for any cleaning procedure. Dr. Cotton, do you have any other comments or specifics about dental procedures?
You did a nice job summarizing. It's important to take good care of your teeth. We do see sometimes infections can get pretty bad and can even infect the heart valves. So we do want to make sure people take good care of their teeth. I agree with everything you said. There's a question about liver transplant from an HIV positive donor, but to be clear, we would only have an HIV positive donor if the recipient were HIV positive. So we don't do transplants in any other situation. And we have had really good outcomes using HIV positive livers into HIV positive recipients, would be my bottom line. And we're routinely doing that for kidneys and livers, and kind of exploring that for thoracic organs, or heart and lung. I don't know if anybody wants to add to that.
Yes, just that the testing that gets done is quite good on the potential donor organs, such that we screen for HIV before accepting offers. But yes, the heart program is eager to begin an HIV positive and HIV positive program to mirror what's being done in the abdominal programs.
Greg, if I may ask, is the heart program doing hepatitis C transplants?
Yes.
Great.
We began that a number of years ago, actually with the help of colleagues on the call here, particularly Emily. We launched the first protocol where we received hospital buy-in for upfront treatment with Mavyret for the pan genotypic coverage, and then accepted Hep C viremic hearts with an average number of waiting days of 7 days when we started the program. So one of the years of our program, over half of our hearts were Hep C viremic, and none of them resulted in patients having long-term infection. So we continue that practice, as does now just about every program in the country. So we're doing fewer of them, and fortunately, hopefully more people are getting treated so that there's less people that have Hep C positive. But yes, the short answer is we are doing them, and we've had very good outcomes because of the advances in the treatment regimens for treatment of the Hep C viremic hearts.
I assume we're doing them in lung and having good results as well.
Yeah, Hep C positive donors in lungs is standard of care now.
Standard of care.
And we do about a quarter of our lung transplants were Hep C positive just a couple of years ago. And we also are getting ready to start a HIV positive into HIV positive pathway for lung transplant recipients, which would increase the availability of organs for those patients living with HIV.
And I think as a follow-up to those comments, just for the patients on the call, there's really just been, since 2016 or so, an entire change in the landscape of hepatitis C. I think there's memory of the treatments people used to receive to try and treat or cure hepatitis C, interferon, ribavirin, regimens people were on for even up to a year, made you feel like you had the flu, had a lot of side effects, really suboptimal cure rates, very low chances of curing the infection. These new agents are pills, taken once to a few times a day, regimens as short as 8 weeks up to 24 weeks, but usually somewhere in between, with cure rates in the high 90s, right? And so I think what the program has said here is that all the patients that we've transplanted that have received a Hep C positive organ, all of them have been cured of the hepatitis C afterwards. And so things that have really kind of changed the face in the discussion. And so when hearing about an organ that might be Hep C positive, just knowing that it's something we're working hard to try and treat and cure, and a potentially very viable organ that we want to be able to use to help, whether it's lung, liver, heart, kidney, etc., move things forward. And similar in the hepatitis B, what people were talking about, maybe starting to talk about hepatitis B and what implications that has for hepatitis B positive organs and how we think about their use as well.
Great. There was one question about differences between tacrolimus and envarsas. So these are in the same category of anti-rejection medications that we use post-transplant. The major difference between the regular tacrolimus and the envarsas is the way it's absorbed in the intestine. So the envarsas is a slower absorption, so you only take once a day instead of twice a day. Majority of our patients are going to be on a regular tacrolimus. With a few exceptions, some patients may develop significant side effects from the tacrolimus, the regular one, and then we switch them to the envarsas, which is this slower absorption. Truly, there's no difference in terms of kidney toxicity, in terms of any side effects related to the kidney in particular. But everyone is different in how they break up the drugs and some of the metabolites that form from these drugs in terms of side effects. And so we do assess each patient individually, and if they're not tolerating one medication, we always look for an alternative, as to try to promote as much as possible their quality of life.
There's another question in the chat regarding how safe is it for, it says lung transplant, but I would say for any transplant recipient to eat out at a restaurant. And I think the current situation is in a much better place than it was just several years ago in regards to the risk of acquiring things like COVID. What I tell our patients is when you're going to be in a very crowded area or exposed to a lot of people at one time, obviously the risk of catching a virus or a cold increases. So kind of do what you feel comfortable with. I always encourage our patients to have a mask with them. So if they are sitting in a crowded waiting room, they can have their mask on. And then when they're seated at their table and ready to order and eat, they can take their mask off and enjoy their dinner. you go through these transplants to really get your life back and to get back to doing the activities you enjoy. And so I do think you can do these activities safely, but just be aware of your surroundings. And if you feel uncomfortable that you're at, maybe at a higher risk of being exposed to something, then either remove yourself from that situation or take precautions like wearing a mask to reduce your risk of being exposed to these respiratory viruses.
Excellent. There are a few questions on the kidney side about, and this is interesting because we can even do a comparison between different organs. So when are patients placed on a waiting list for a kidney transplant, and how long does it take for them to get to the top of the list? This is a common question. We tend to place patients on the waiting list once their kidney function is about 20%. So that's what we call GFR of around 20 mLs per minute or below. Of course, some patients get very late to be assessed by us, meaning sometimes they're already on dialysis and therefore they get listed right away. In the kidney transplant, the waiting time is defined by the first time you are placed on the waiting list, and that accumulates, and then you start getting, higher and higher on the list. Unfortunately, in our region, it takes, between 4 to 6 years for you to get to the top of the list to get a kidney transplant. The best option for the majority of our patients is if they have a living donor, they can bypass that and get a kidney in a much more timely manner. For those that do not have a living donor, what ended up happening is that they have to stay on that waiting list until they get to the top. According to blood group, there's some differences. For example, blood group O, it takes the longest, followed by blood group B, and then A, and then AB tends to be about 2 to 3 years. So depending on your blood group, which we have to assess the compatibility between donor and recipient, your waiting time varies. Every 6 months, the kidney transplant candidates will receive an update of where they are in terms of waiting time on their list. There's a ladder that goes to every patient. And so you can look at the ladder and have a sense of where you are according to your blood group and how long it may take for you to get to the top of the list. Again, highlighting the importance of potentially looking for living donors, and a webinar that we have on a monthly basis to discuss how can you get a living donor and learn from others that have gone through the process. I don't know if my colleagues want to chime in terms of some of the differences in terms of that in relation to the kidney.
I can start, Leo, just because I think we're maybe at the kind of opposite end of the spectrum in some ways. We have some patients who come onto the heart transplant list and they're on the list for long periods of time, particularly if they're at a status level of 5 or 6 and are waiting at home. But if we look at national trends for heart transplantation, the majority of heart transplants are now taking place in patients that are status 1 or status 2. And the only way to get to that status is to essentially be in an intensive care unit in the hospital where you're going to be transplanted, and typically with the assistance of devices to help the heart pump blood. And those situations result in the need for very expeditious transplantation. So we have had patients who have come into us, arrived at MGH, been worked up, been listed and transplanted all within a period of 24 hours. So some of our transplants happen very quickly, and other patients wait just purely based on acuity, and of course the fact that we don't have a dialysis option to keep our patients supported for their heart function many times.
In lung transplants, our average wait time at MGH is about 2 months. That's including everybody, but we have our wait list is based on a scoring system that takes into account medical urgency, so how sick someone is, but also their expected survival after a transplant. So it's a very complicated formula. And so the sickest people that are, again, in the ICU, like Dr. Lewis was mentioning with the hearts, that are in intensive care, they typically get transplanted much quicker. Patients who are at home on low amounts of oxygen and relatively healthy compared to the others on the list can wait longer. And there's also some differences, as was mentioned, based on blood type. With the same blood types O and B, waiting a little bit longer than blood types A and AB.
Dr. Bethea?
Thanks, Cleo. Sorry about that. I was answering a question and want to make sure I'm completing this one correctly. Is this largely about the living donor front for liver?
We're talking a little bit about it can be as well living donor, which I think is very unique for the liver as well, but also, how do people get transplanted? How does the waiting list kind of works?
Yes. And I saw Brian talking about continuous distribution. So liver is an allocation system right now solely based on urgency. And so when we talk about how livers are allocated when they come in from deceased donor transplants, it's solely based on your MELD score, so that liver sickness score. And our MELD score is composed of a few factors, all that come from blood work. And so it's your creatinine, which can be calculated based on blood work in your GFR or through cystatin C. We have it based on albumin, your bilirubin, your INR. There is an input from gender. And those all go together for a formula that'll spit out your MELD, which stands for your model for end-stage liver disease. Sometimes the MELD score is not entirely reflective of disease severity. So there are ways to get what's called an exception point MELD. So maybe your natural MELD score when your blood work is drawn is 12 or 13, but you're having a number of complications. There are ways to apply for an exception point MELD, but there are standard things for which exception points are granted and others for which they're not. And so liver cancer, those sort of things have standard exception MELDs. Other things don't kind of fall under that bucket, but the team can absolutely work and talk with you about that. And then similar to what the other organ system said, in general, patients who are blood type O and A, there'll be more donors that come forward, but also more patients on the waiting list with those blood types. A, B, and B are more rare. So as those donors come in, sometimes the wait times are shorter. And then for living donation, we go through a similar process as some of the other, just kidney sort of chatted about, in that in living donation, the only thing that impacts wait time is finding a suitable donor. So if someone is eligible for transplant as a recipient and there is a donor that becomes available that's a suitable match for the recipient, then it's just about timing and scheduling, and less so about the allocation system or the MELD score.
Wonderful. I think there's another question that I think may be relevant to all the organs. As soon as I get a call, and this is a patient stating, for an organ, how long do I have to come into the hospital in order to get it? And I'll start with kidney. I think it really depends, because sometimes the kidney has already been procured, has already been removed from the donor, and therefore we have about 24 hours on the kidney side to actually place that kidney. Sometimes we can know a day or two ahead that most likely we'll have a potential donor, and you've been selected as the top candidate for that, and that would allow us to have a little bit more time to plan. So what we say is for most of our patients, in particularly when they start getting to the top of the list, is that they have to have their phone next to them, have their, a little bag kind of ready, because things can happen very quickly, and it depends on so many different factors. I know for some of the other organs, it may be even sooner. So I'll pass it on to my colleagues.
Yeah, just to make one point, I know that Shimel made this earlier. I think regardless of what organ system it is, when we start to get patients up towards the top of the list, whether you've kind of finally made it to the finish line in the kidney transplant process, or if you're waiting at home for heart, it is particularly important to inform your transplant team if you've had a significant kind of change in your health status. If you've been unfortunate to come down with a significant respiratory illness, if you have a febrile illness, we are eager to reach out to you to let you know that we've got an offer for you. We want to hear from you, because we don't want to have a situation where it is a time-sensitive matter and we call you up and it turns out that we've looked at a heart or another organ for several hours and found the perfect fit for you, and then it turns out there's a condition that's going to make it not possible for you to be transplanted at that moment in time that will hopefully pass quickly. So I think that communication bidirectionally is so important as you get to the point of being on the doorstep of getting your transplant.
Can I add one thing that's a little bit different than what you all are saying? One of my tenets is our job is to get you an organ somehow, some way. And so if you are on the list, you just need to be ready just in case you may get a call at any time. Even if you are told you're going to be waiting 5 years, waiting 1 year, waiting 1 month, there are different times when an organ is suitable for you and not suitable for the other 20 people ahead of you. And that is based on the judgment related to what's going on with the organ, maybe where do you live, blood type, different factors. For liver transplant, more than, and I guess, yes, actually for heart as well. I don't want to talk out of turn, but for us, size really matters. And so a lot of times we will bypass patients because the liver's big and I need a big recipient, or the liver's small and it's an opportunity to do someone that's small. So I would say if you're on the list, just be mentally prepared. I want you to live your life and travel and do what you're going to do, especially if you're, not close to transplant, but be prepared. You may get a random call on a Tuesday night at 6 p.m. to say, come in for a 9 p.m. transplant. Thanks.
And I will just follow that up with one thing to say in general, in terms of how close you have to be. Chimel or Dr. Shaw may have just said, 6 to 9 p.m. We will talk to you, especially some of you who live farther away, and our ability to try and take measures, for example, with organ procurement and what else is going on, things like using a pump, or if we need some more time for you to physically get here, we can. And that time range, just as Leo said, can vary a bit based on where you live and those factors.
Putting the organs on a pump, and all our organs now can go on the pump, has completely changed our field. So if you live in Maine, Vermont, things like that, you will have time to come in. I just need to put it on the pump and wait for you to come. So it won't be an organ that's lost for you if that happens. That wasn't the case 2 years ago. I came from Cincinnati, and we used to have patients from around the country come. I used to actually have them move to Cincinnati when they were close to the top of the list, just so they would be there for an organ. That was before we were using the pump so regularly. So as an example, now Cincinnati is a lot cheaper to live than Boston, so it's a little bit more feasible as I'm learning. But that's an example. I think now the times have changed. You can be home and don't worry. But it is a little easier if you live in Watertown, or somewhere close by than if you live in Maine. But still, with the pump, I think for all of these organs, it has changed the way we can practice, and we can wait for you to come in.
I saw there was one question about getting a total knee replacement after transplant. And yes, that is definitely something that we do on a somewhat regular basis. So that shouldn't be a problem. We do hope that people are, feeling strong and healthy and have really fully recuperated from the transplant. So the longer we can, sort of wait after having the transplant, usually the better it is. But that is definitely something we do. The goal is to keep you healthy and strong and living a full life.
I had a question for Dr. Keller, and I don't think we addressed it, but I had to step away for a minute. What is the waiting time for a lung? I know the program is growing in lung. Are people getting transplanted within months, or is it years, or how long does it take?
Yeah, our average wait time is about 2 months now.
Wow.
But for
Okay.
people that are in the hospital and in the ICU, it can be much shorter, and 24 hours to, a week or two.
Okay. So anyone that gets on the list should be ready to go potentially then, because the list is probably not that big.
Correct. I mean, we now have a national list. So we take organs from anywhere across the continental United States, and we've gone to Alaska each of the last 2 years for donors. So it has really expanded the availability of donors for our patients here in New England, whereas previously we were restricted geographically. So that's, I think, been a very big help for our patients to be able to get transplanted faster. And yes, I've had patients go on the list and get an offer within hours. And others can wait a little bit longer, but it is a surprise, I think, to a lot of patients, because you hear a lot of information about the waiting times for other organs, and then when you talk about lung and it being relatively short, it can be a little bit of a surprise. But as you said, Dr. Shaw, if you're on the waiting list, no matter what organ you're on, be ready, have your phone with you, and just be expecting that call. There were a couple of questions, and maybe Dr. Riella can help me with this regarding sometimes after a lung transplant and possibly other transplants, other organs such as the kidneys can be damaged, and sometimes this damage can occur in the process of doing the lung transplant surgery, and sometimes it can be occurring over a much longer time. When you take transplant medications for a long enough time, there can be some slow damage that accumulates in the kidneys, and sometimes that damage can progress to the point where a kidney transplant may be needed after, say, a lung transplant. So there were a couple of questions about that. So tacrolimus of our transplant medicines is the one that over time can build up an effect on the kidneys. For those patients who do develop kidney injury early after transplant, so at the time of the surgery or over the first few months, there is a program called a safety net kidney transplant program that was recently started over a couple of years ago, which helps lung transplant recipients who develop kidney injury as a result of their lung transplant to obtain a kidney transplant in a more expedited manner. There are some special nuances to that I'll defer to Dr. Riella in describing, but that has been a big benefit to helping improve the outcomes and the survival of lung transplant patients who do develop kidney injury.
I think Dr. Riella had to step away, but I will say that certainly that is a great option of being able to provide a kidney for someone after a lung, heart, or liver transplant, because it does happen as you eloquently described. And this is an example, I think, of how great our program is. Everyone is working together. Doesn't matter what organ you are. But the fact that your care was already in our system, we know everything about you. It might be a different organ, but it's a teamwork where we're looking to help all the patients, whether you are on the heart transplant program or the lung transplant program. If you need a kidney, I think they're invested in making sure that we can do it as long as it's safe to do. And that's the one thing that happens. Sometimes patients are so sick that maybe they can't get a kidney and they have to be on dialysis and things like that. But we work together as a team. And I hope that patients that see all of us here on the call today would recognize that, because I think that's very rare to have all the organs represented in one call, including infectious disease, which brings it all together in the middle.
So an organ, we'll give it that.
Shimel, it's a great topic. We work really well as a transplant team, remarkably well. And I think people tend to see us separately, but it's amazing how we have this wonderful transplant village that all works so well together. There was a question about numbers in our program. Does anybody want to comment on transplant numbers over the past couple of years? Brian, Greg?
Yeah, I think Dr. Riella kind of listed all of those. So last year at MGH, there were 223 kidney transplants performed, 78 liver transplants, 52 heart transplants, and 67 lung transplants. And I think those numbers are continuing to increase. I'll defer to all the other organ programs in terms of how things are going for them this year. We've currently done 24 lung transplants as of today for 2025.
Yeah, I'm proud to report that I'm sorry for not being dressed appropriately, but I'm going back in tonight. We're going to do liver number 71 tonight. And last year we did 78 for the year. So we've really opened up the boundaries of what we can do. The outcomes have been great. The teamwork and the facility and all the different facets of what it takes to get a patient through the system has been really impressive. And so we've been able to expand pretty quickly and not at all what I was expecting. So we are well ahead of what we were expecting to do.
And I think Shibble, with that comment, Greg, well, actually, Greg, I'll let you go first, but I just saw a question in the chat about living donor in the liver space, and a question on, if afterwards you'll be able to recuperate together or see each other as you go through the living donor process. There are things about rooming, et cetera, based on gender that kind of come into play. But of course, when people are in recovery, some might be in the ICU initially, some may then be coming down to the floors. But there is no restriction on you being able to, communicate or see each other. And the hope would be if you wanted to walk the halls together or do those things, that would be fully supported. I don't know, Shimon, if you have another comment, and then I can go to Greg too on numbers.
No, you said it exactly right. It's a team process there, and the donor and the recipient, and we do set up rounds where the donor can go visit the recipient and they can be together and hang out and things like that and take pictures and stuff. So we want it to be a unified process, and it's a great thing. Living donation is something that not only brings the most amazing part of it is not only does it bring a family together or two friends together, it actually brings our program together because there's a lot of pride and unity and going through the whole process and having the case done. And we have our first one on Monday after a while, but have a few more already booked. So we're excited to bring this facet also to our patients because in the end, our job is to provide access to patients. And to me, living donation is another aspect of access besides the deceased donors and things like that. So we're excited. And I think this is something that we should be offering as a elite institution in all the organs. And we're not there yet with the thoracic organs for living donation, but maybe one day.
Mm-hmm. Yeah, and I'll comment on the heart side in terms of volume. First, I want to congratulate my colleagues on the call for the unbelievable growth that we've seen in the other organ systems. In the heart world, we had 3 or 4 years ago, we had a big jump up in our volume, such that over the course of the last 4 years, our volume it is a proportion of the total heart transplants done worldwide. We've been just under 1% of the global volume, and we've been maintaining that, and we're looking for ways to grow, but we've been consistently in the 50 plus zone, which does put us into one of the higher volume programs nationally. And it really is great to be part of a transplant center that does all of the multi-organ transplants. There's a lot of programs that don't offer heart, liver, and heart, kidney, and heart, lung. And so that is really kind of a pinnacle of collaboration when we perform these multi-organ transplants on highly complex patients. So that certainly takes a team effort.
There was a question in the chat about can you ever wean off tacrolimus? Who wants to handle that question? Emily.
Great question. So maybe there's two things here if I'm reading behind the lines. One, can you ever wean off a specific immunosuppressive medicine? And two, can you ever wean off immunosuppression altogether? The first one is much easier to answer. So, for a given patient, based on the organ, there's often what we think of as cornerstone immunosuppressive medications. So for example, in liver transplant, after transplant, it's most common for most patients that you start on steroids or prednisone after transplant. You're usually on an anti-metabolite, so something like mycophenolate mofetil, CellCept, or Myfortic. Then you're also on tacrolimus, and tacrolimus has also been felt to be the backbone. And so over the next 3, 6, 12 months, usually we wean off the steroids in short order, goal by a month, sometimes a little bit longer. By 6 months, oftentimes that antimetabolite, Myfortic, CellCept, et cetera, is weaned down and sometimes off by 6 months to a year. And then long-term, you're on the tacrolimus. Most patients need some immunosuppression. And so while there's tolerance studies and a lot of research being done on how you can wean and which patients you can wean, or maybe being able to be on minimal immunosuppression, we aren't able to fully get people off of everything in by far and away the vast majority of cases. And so pre-transplant, we talk about that with that expectation. There are in some patients certain conditions they may have, which make one medicine more attractive than another. And if that's the case, for some reason, tacrolimus is one that based on drug-drug interactions with another therapy you're on, or based on other conditions you have where other regimens are preferred, then maybe you can be weaned off tacrolimus on an alternative. If that's a liver-specific answer, but in general, I think most times people are on their tacrolimus long-term. It's a very good anti-rejection medication, and it's one that we try and minimize side effects and other things from if we can. But that's probably the shortest answer with a little bit of a liver-specific spin.
There's also a question about weaning off of prednisone. I know that all the different organ systems have different protocols. we certainly do that oftentimes in the heart transplant patients, we're trying to find the path of least side effects for patients. So sometimes that means a low dose of tacrolimus with maintaining steroid exposure and mycophenolate. Other times we're able to come off of the prednisone completely and go down to a two-drug regimen. So really individualized to try to optimize the regimen for each patient.
There was a question in the chat about well water, and because it's heading into the summer season and we do see people traveling, if you are on a well, like a private well, not just a city or town well, you should either boil the water or drink bottled water. And if you're traveling somewhere, something rural, a cabin or something like that that's on a private well, you should also boil the water or drink bottled water. There are a lot of things that can seep into well water, and we don't want you to get sick. And I always say, I hope you don't have any special visits with me. That's the goal, is to avoid infections. And along the lines of travel, if you do have some upcoming travel to anywhere exotic, anywhere, outside of, say, Europe, Canada, Australia, I'm happy to, or like outside of the routine Caribbean destinations, I'd be happy to see you in Travel After Transplant Clinic.
Dr. Cotton, we did have a couple of questions come in about nutrition and lifestyle. So I have Paul Foster, who's one of our transplant dietitians. Paul, can you confirm that you're in as a panelist?
That's great.
Paul, are you there? All right, well, while we figure out that piece, are there any other questions that you guys would like to answer?
I think quickly, I just see one on there about belatacept. Why might someone be on that over other agents? I can just say quickly, every patient and every organ will have nuances. And for some patients, it might be a better agent to use for induction. It might be, as I think some people mentioned, tacrolimus might be one that when we're thinking about the kidneys or how they're doing, or maybe giving them a little more time to recover after transplant, trying to use a different agent that maybe isn't as stressful on the kidneys around the time of the operation, or longer term. There's good reasons that people might be on belatacept based on matching organs up front, both in kidney, lung, and heart, less so in liver. But welcome any input from Brian or Greg as well.
We don't actually use belatacept with lung transplant right now. There was some small studies in lung transplant that did not have great outcomes in our particular population. But I think in other organs, it has definitely been shown to be effective in certain situations. So I can't really speak to the effect, the transition in lungs, although we continue to explore ways to either use new medications or different combinations of medications to improve immune suppression.
For belatacept, it does look like some of the outcomes are potentially beneficial, but that's something you'd want to talk to your kidney transplant specialist about. But it's certainly an option, and we have a very good program for that. Anna, are you able to speak?
Stacy. Yeah, Paul and I are here now. My microphone is working. Can you guys hear me?
Yes.
Okay, great. Paul and I just wanted to add a little bit to the restaurant question as well. Definitely important to mask. We also encourage people to make sure that, in terms of like animal proteins, which are a little bit higher risk, just asking for those to be cooked well done if possible, to eliminate possible undercooking of meats. And, we hope that all restaurants are trained in food safety and those parameters, but we just want to take a little extra precaution. We also recommend against buffet and salad bar type settings as well, just for high risk of transmission of, illness. And Paul, if you have anything to add to that as well.
Yeah, no, thank you. I think that was a great summary and addition, Hannah.
Great.
I think there was Yeah, there
Yeah.
was another question from the original registration. Someone had to ask kind of do's and don'ts as far as nutrition, and it will really depend on your where you are in your transplant journey. Nutrition will be individualized depending on your underlying disease. So recommendations for kidney disease are going to be slightly nuanced from liver or lung. And then it will also depend if you're pre or post transplant. Those recommendations for nutrition will be slightly different. So definitely connecting with a dietitian through your nephrologist or your primary kidney doctor, or through your hepatologist or your GI clinic. And then you would also be meeting with one of the transplant dietitians as part of your evaluation as well.
There's a question in the chat about cannabis gummies in moderation. And I think the recommendation has been that we are cautious about that because of potential drug interactions, because the gummies are actually not a controlled product. Does anybody, and we don't really like smoking marijuana, like smoking a joint, that type of thing, smoking weed, in that that one we do know that there is a higher risk of mold pneumonias. Brian, Greg, Emily, do you have
Um,
comments on that?
I can also add to that, Camille.
Please,
Usually in
please.
the kidney realm, it's mainly the CBD component of edible marijuana gummies that interacts with the tacrolimus. Obviously, since it is not a controlled substance, there's always a risk of additives being there that, we don't know about. So, that could always be a risk. But if someone, were to use it, we mainly recommend pure THC gummies. But if you can avoid use, that's ultimately, the best option.
I think to Hannah's point too, risk tolerance is something that we all deal with in everyday life, right? What we're comfortable doing, what we feel like is acceptable, and then also as providers, what we feel we want to be recommending for patients. And so with anything that's not, quote, FDA regulated or kind of looked through, there can be impurities or additives or things that might cause liver toxicity or might cause other issues. And so I think what Hannah and Camille said are what most of us probably relay. But just emphasizing that the inhaled marijuana is something from the pulmonary infection standpoint that we are strictly no on. The gummies are one where just avoiding the CBD is the biggest concern, and kind of talk through those pieces. And just note, if you're trying something new, if it's a new supply of edibles or something different, kind of making a note so that if there is something going on with your immunosuppression levels, or when your coordinator calls and says, hey, it looks like X, Y, and Z is going on, anything new, that's something to relay so the team can take it into account and make sure that there is or isn't an impact going on.
And regarding lung, obviously, we want to avoid inhaling anything that could potentially directly damage the lungs themselves. So that includes anything combustible, so cigarettes, cigars, marijuana, other inhaled drugs, and including inhaled toxins. So sometimes these can be chemicals that you're exposed to either through work or through hobbies, and vaping devices as well. Those can all cause inflammation in the lungs and can cause problems after lung transplantation, in addition to the drug interactions that were previously mentioned by the other panelists.
And maybe we'll wrap up with there was one question: how concerned are we about the recent cutbacks in funding, and might that have a negative impact on the great work you do for us? Many are worried. And I think at this point, we don't actually have enough information to really answer that question, but we do remain concerned. And I will say these very supportive messages during this webinar are really very much appreciated. It's been a bit of a hard time in science and medicine, so we are appreciative of your comments. I think we're getting near the end of our hour. Stacy, is it time to wrap up?
Yeah, we are at the hour, and I do want to thank all the panelists for making the time to come this evening, and of course, all of the patients and loved ones who were able to join. We love hosting these for you. There will be a post event survey. Please fill it out. Let us know some of the topics you want to hear about, so that we can make sure that we tailor these webinars to your needs and wants. This program has been recorded. It will be posted on our YouTube page in about a week, and we will send out the slides that Dr. Cotton had prepared speaking about infectious diseases, particularly measles. I know there are a couple people who joined late. I don't know, Dr. Cotton, if you wanted to kind of give a quick summary of the takeaways for that, and then we can wrap it up.
Sure. So there were a lot of questions about measles. Most people born since the late 1970s had 2 doses of measles vaccine as standard American school children. Other people born before the late 1970s, we actually tested everybody before transplant. Anybody who had a negative measles test, which is about 4%, so not very high. 4% of people that we test had a negative measles test, and more than half of them, we gave them a measles booster. So we have been looking at this for over 20 years. We were looking at it, I think, long before any other programs were standardly looking at it. So I'm sort of proud of that. And most people are well protected. I would emphasize that you should not get an MMR vaccine after transplant if you are on immune suppressive agents, as it could cause severe side effects, including things like a brain infection or lung infection. So don't go get yourself an MMR vaccine just because you heard about it on the news. Like, talk to your transplant team first. And at this point, because we have very low disease rates in New England, we are not recommending wide-scale testing. Most of you had positive testing prior to transplant, and that's the answer we would stick with. So nothing more needs to be done at this point. But we are definitely primed to do more if there is to be significant disease activity in New England. We're actually doing a lot of webinars and research and such. And I have a fairly large research project on that, and I'm very appreciative if any of you on the call have contributed to the measles research project I'm doing. So thank you.
All right, any last words from our other panelists?
Just thank you to everyone from joining, to colleagues, but to the patients and the transplant community. It makes a difference to be able to chat with you. We want to hear from you, and thanks for taking the time to join.
Well said.
Take care, everyone.
Have a lovely evening.
Bye-bye.
Have a great
Thank you.
summer. Bye.
Thank you.